A very good morning to everyone and a warm welcome on behalf of UN Mehta Institute of Cardiology and Research Center, Ahmedabad, to this academic program. This is a learning initiative from our institution directed towards the students of cardiac surgery and to all those people who are interested in this fascinating field of cardiac surgery. The topic that is given to me is aortic valve replacement, and without wasting much time, we'll go straight to the topic. This topic I'm going to cover under the heading of indications for aortic valve replacement. Then we'll see how a conventional aortic valve replacement, whether it may be with mechanical or bioprosthetic, how it is conducted. Then we will see how an aortic valve replacement is done with other types of valves like sutureless valves or aortic homografts. We will also see quickly how Ozaki procedure would be performed. Then we will see how these principles of open surgery can be applied to perform a minimally invasive AVR. And then we'll see a couple of difficult scenarios which can cause problems in our clinical practice in which we might be forced to do AVR. And then we'll briefly touch upon transcatheter aortic valve replacement. Before I start with my presentation, a small disclaimer here that I have used a lot of images and multimedia which have been taken from published literature and from the sources of internet. I don't have any copyright on them, and I sincerely thankful to those people who have done these publications and presentations, and have used them only to emphasize on certain concepts and to explain certain scenario, and I have given all the due credits to them in the slides and as well as its references later. Okay, so to begin with, we will see what are the indications for aortic valve replacement. So primarily, aortic valve replacement has two main indications in a setting of aortic stenosis and in a setting of aortic regurgitation, when the valve is become stenotic and the valve has started to regurgitate. So these are the main indications for aortic valve replacement. And if we see the new guidelines which have been published in 2020 by ACC, it has categorized the disease of aortic stenosis and aortic regurgitation each into 4 stages. So stage 1 is when the person is at risk of developing the disease. Stage 2 is when the disease is set in and is progressing. Stage 3 is when the disease is of severe form, whether it is aortic stenosis or aortic regurgitation. However, the patients remain asymptomatic. This can be further divided as C1 and C2 depending upon how the LV function is. Stage 3 is when patient has severe form of disease, at the same time they are symptomatic. So if we briefly look at the indications, then we see that the aortic stenosis, when it is in stage D, becomes a class 1 indication for AVR. Similarly, when it is in stage C and when the LV function is down, or when we are doing any associated cardiac surgery along with the presence of AS, it becomes a class 1 indications to do AVR. Similarly, if we see aortic regurgitation, all symptomatic patients of stage D are class 1 indication for AVR, and those patients who undergo other cardiac surgery in presence of stage C AR, as well as those patients who have LVEF less than 55% becomes indication as class 1 indication for AVR. Coming to the steps of aortic valve replacement, as in any other cardiac surgery, we will do this procedure under general anesthesia, and we'll introduce all the monitoring lines, catheters, and the necessary precautions to be taken for any cardiac surgery. Usually the surgery is conducted in supine position. We should make sure that all pressure points are well padded to prevent any pressure injuries. Step 1 is to do a standard midline sternotomy. Then we will heparinize the patient to achieve the desired ACT of 300 to initiate cannulation and 400 to go on bypass. Usual cannulation strategies would be to do an ascending aortic cannulation and a 2-stage RA venous cannulation. However, in certain settings, like in minimally invasive AVRs, or when we are doing redos, we might have to resort to other arterial cannulations like femoral or axillary, and a femoral venous cannulation might be the appropriate option in these situations. Next step is to cross-clamp the aorta. Now, when we come to stage of cross-clamping in aorta, myocardial protection has to be given due importance. Following are the common principles which we need to follow in achieving good myocardial protection, and it cannot be emphasized more than enough to prove this point that good myocardial protection is very essential for good outcome following cardiac surgery. So systemic cooling We usually cool the patient at around 28 to 30 degrees Celsius from cardiac surgeries, but there are certain institution and surgeon preference varies from cooling the patient to like even drifting the temperature to 34 to 32 degrees Celsius for AVR. So again, it varies from surgeon to surgeon and from institutional or unit policies. There are various techniques by which we can give cardioplegia, like we can give cardioplegia into the aortic root through ascending approach, through antegrade approach, or we can give it through the coronary sinus through a retrograde approach, or we can open the aorta and then give to direct ostial approach. So this appropriate method of cardioplegia again depends on surgeon as well as the primary pathology that we are dealing with. Like when a patient is having disease of aortic stenosis, we might be okay to give root cardioplegia. However, when we have patients with aortic regurgitation, then it may not work well, and we might have to give either direct ostial cardioplegia or retrograde cardioplegia would be an appropriate approach. Similarly, there are various choices of cardioplegia solutions which are available. We can use blood cardioplegia, we can use crystalloid cardioplegia, we can use del nido cardioplegia. So these are different types of cardioplegia which are available, and depending on surgeon preference and patient's kind of disease that we are dealing, we need to make an appropriate choice. Venting of LV is very important. Usually it is done by putting an RSPV vent into the LV, and sometimes in minimally invasive or in redo situation, it might be difficult to put RSPV vent. So we can vent either by a PA vent, or we can put a vent directly into the LV across the aortic valve. Regional hypothermia with cold saline or ice is again individual's choice or preference. It again helps to decrease the myocardial activity and have a better effect on myocardial protection. So once we have cross-clamped and given cardioplegia, the next step is to proceed towards aortotomy. There are three main types of aortotomy that we do for a standard AVR. Either we do a transverse incision aortotomy. So incision usually commences around 1.5 centimeter above the origin of the right coronary artery, and in a transverse fashion it is advanced in posterior direction. Oblique aortotomy, it starts again with a similar point and then it winds around between the aorta and the RA and directed towards the center of the non-coronary cusp, or towards the commission between the non-coronary and the left coronary cusp. And the third approach is when we transect the aorta completely. Usually starts as a transverse incision and then we divide the aorta to get a better exposure of the aortic valve. Again, aortotomy is a thoughtful decision. It depends on many factors. Like if we choose, depending on what kind of prosthesis we are using, like if we are using a sutureless valve, then we need to make a very high aortotomy. So a transverse aortotomy which is made very high would be beneficial. Similarly, if we need, if you are thinking that we might end up with a root enlargement procedures, then oblique aortotomies might be a good option. And similarly, if we are dealing with cases like infective endocarditis, where we anticipate that there might be major problems and we might end up with root replacement, then transaction of aorta might be a good choice in this situation. So again, it's a thoughtful decision, and this decision is always or most of the time made before we start the procedure. Coming to the next step, once we have opened the aorta, we need to get good exposure of the aortic valve, which can be achieved by taking desired stays along the aortic wall and also along the commissures, and pulling the valve up can give us better exposure of the aortic valve. So classically described method of excision of aortic valve is to commence at the center of the right coronary cusp and extend from free edge towards the annulus, because there is no vital structure underneath this cusp, and then we extend it on the either direction to excise the valve. However, in common practice, many of the surgeons also prefer to start from each commissures and then to extend downwards towards the nadir of cusp to excise the valve. Whatever technique we follow, we need to excise valve without causing major damage to the aorta, to the ventricular muscle, or to the important structures around it, like the membranous septum or the aortomitral continuity. So we should carefully excise this valve. Sometimes heavily calcified valve might be a real challenge in debridement. So debriding calcium is important so as to prevent any paravalvular leak if we don't debride them properly. And also while debriding calcium, we should take care that we don't have any debris getting embolized once the surgery is over and can cause embolic strokes. Sometimes we might have to use special instruments like rongers to crush the calcium and then debride the annulus carefully. So we need to take due precautions so that we don't cause much injury. At the same time, we should get optimal debridement and proper excision of the valve. The next step is to size the annulus. Now it is important to use the sizers of the same manufacturer of the valve that we are going to use for our valve replacement. Coming to the next step, I will implant the aortic valve in the annulus that we have already debrided and sized. Now there are certain things that I would like to highlight at this point. Is one of the most important thing is to decide where we are going to place this aortic valve. This figure is taken from a product monologue of Zorin. Just to highlight this point, in this slide we can see three different positions of aortic valve. In the first thing, it shows the intraannular positioning of the aortic valve. In the second, it is partial supraannular, and third, it is complete supraannular. Now why this is important will be clear from this figure. And if we see here, when the valve is placed in intraannular position, the sewing ring and the housing occupies quite a bit of the available internal diameter. And as a result of which, we may not get a good flow dynamics as compared to what we would have got if we had a supraannular valve wherein there's not much loss of the internal annular diameter that is available for the blood to flow. This will be clear if we see the flow of jet of blood that is shown here and with the intraannular valve as compared to that of a supraannular valve. So depending on what kind of valve placement, we may expect a better hemodynamic performance. And once we have decided this, accordingly we should take our stitches. So if we are planning to place intraannular valve, then we need to take horizontal plageted stitches as shown here, which are everting in nature. So the plaget remains on the aortic side and the sutures come out below towards the LV side and then go through the valve. And once the valve is seated, it remains in intraannular position. In contrast to this, if we are thinking of placing the valve in supraannular position, then we need to take horizontal matrix stitches with plegets towards LV side. These are non-everting stitches so that the valve just sits on the annulus as shown here. One word of caution here, while we are tying, we have to be careful as we cannot see the plegets while we are tying, so we should have a good judgment whether our knots are tight, and we are not leaving any gaps so as to prevent any paravalvular leak in postoperative period. This illustration explains different types of stitches which we can take to seat and valve. So as we already have seen, we can take plegeted stitches with plegets towards LV, which are the non-everting stitches, and towards aorta, which are the everting stitches. The same stitches can be taken without pleget also, but we should be sure that our annulus is good. The other types of stitches which I would like to mention are simple single stitches. So one stitch from the annulus, one stitch from the valve, and then tie it. The problem with this is it can become sometimes very messy with a lot of stitches coming along the annulus and too many stitches to tie. The other technique which is important is continuous technique. Again here continuous stitches are taken from the annulus and the sewing ring, starting from the nadir and then progressing towards the commissure. And then we finish it from one cusp, then second cusp, and then third cusp, and then the valve is parachuted down and then tied at the commissures. Again, we should be very careful about the quality of annulus in this technique. And also, when we are sliding the valve down, we should be careful that we should not cut through any suture through the annulus. With these precautions, this is a good and fast technique. However, if we don't select the patients properly, then there might be incidences of high paravalvular leak in this technique. So we should take a good decision at the beginning, and best thing is to follow one particular technique. So it is better to know one kick and practice it 1,000 times rather than knowing 1,000 kicks and practice one at a time. The same rule applies here. So once we have taken the valve down into the annulus, then we should see what is the optimal position of positioning this valve in the annulus. So when it comes to a bileaflet valve, we should always aim to keep the central axis parallel to the septum. When it is a tilting disc valve, we should see that the greater orifice opens towards the aortic arch. And when it is bioprosthetic valve, we should see that there should be commissural alignment of the new valve with the native aortic commissures, so that we don't cause any obstruction to the coronary blood flow. Once the valve is seated inside, it is better to test the valve before we tie all the stitches to see if there is no obstruction that is happening to the free opening of the valve. At the same time, there is no tissue or nothing holding from the valve, between the valve and the annulus. So once we confirm, we tie all the stitches, whether it is continuous or interrupted technique, whatever it is, we tie it and fix it, and then we close the aortotomy. There are different ways again of closing aortomy. We can either close it with a single layer, or we can close it two layer. Two layer could be like a running 2 layers, or we can take first layer as a horizontal mattress, and then continuous horizontal mattress, and then running sutures over this layer. Sometimes aorta may be small, and we might even need a pericardium or a Dacron patch to close the aortotomy. Once we have closed the aortotomy, then we'll move forward to de-air and release the cross clamp. So we stop the LV vent. We feel the heart by asking the perfusionist to slow down the return. Back the lungs to feel the heart again, and gently massage the LV to do de-airing through a root vent. Then we make the patient in steep Trendelenburg position, and we remove the cross clamp. Again, we empty the heart immediately to prevent distension. We stop ventilation, LV vent is restarted, and root vent is kept on for de-airing. And immediately we take RV and LV pacing wire. We ensure that heart rate is satisfactory, and we stop LV vent, gently load the heart, and then gradually wean the patient off CPB. It is very important to do TOE to confirm the positioning of the valve, to see if there is any paravalvular leaks, also to assess biventricular function and status of air. And then if everything looks well, we come off bypass and decannulate the patient in stages. This is followed by thorough hemostasis. Again, it is very important to achieve good hemostasis in cardiac surgery, because one of the things that we should prevent in post-operative period is blood transfusion and re-exploration. So we should try our best to achieve good hemostasis, drain in appropriate places, stage closure as per the protocol, and then we shift the patient to ICU. This was how we will conduct aortic valve surgery conventionally. And again, to speak about post-operative complications, to post-operative management of this patient, it would be beyond the scope of this session. There will be more classes on this. However, it is very important to understand the post-operative management of this patient, because in cardiac surgery, post-operative management also has got a very high role to play in successful outcomes of these patients. Coming to common complications that we are going to see in patients who will undergo aortic valve replacements. The reported mortality by STS database is 3% for isolated AVR, and the survival is 75% at 5 years, 60% at 10 years, and 40% at 15 years. The early complications which we can face are bleeding, low cardiac output syndrome, arrhythmias, renal dysfunction, neurological complications, infections, complete heart block, which may settle or may need a permanent pacemaker which will decide usually after 1 week following surgery. In terms of late complications, we can expect paravalvular leaks, infective endocarditis of prostatic valve, stuck valves, complications related to anticoagulation, and structural degenerations of bioprostatic valve. Having seen how we will conduct aortic valve replacement in conventional manner, now we will just focus our attention to certain developments that have happened, and the kind of newer valves that we have, and what precautions we should take in these settings. So the first thing that we should consider when we are considering a sutureless valve is the aortotomy that we have to do. After standard cannulation and establishment of cardiopulmonary bypass, we see that the aortotomy has to be very high, because if we see the valve, then it has got two portions. First is the skirt of the valve, which remains in LVOT, and the second portion is the stented portion of the valve, which neighbors the valve. So if we see the length of this stented portion, then it is between 25 to 30 millimeters, and that means around 3 centimeters. So in a largest valve, so we should make a very high aortotomy so that this portion remains well secured into the ascending aorta. It's a first step. So usually the site that it described is about the epicardial fold, which we see over the ascending aorta. Once we have done the desired aortotomy, then again we should do necessary stay sutures and get better exposure of the aortic valve. We should do thorough debridement and excision of the valve and thorough debridement of the annulus. Having done this, the next crucial step is to size for appropriate valve. So we should see that when we size this aortic valve, the sizer should not go very smoothly. It should have some resistance, and that is the right size of a sutureless valve. If it goes in too freely, then we should move on to the next size. At the same time, we should see that we should not oversize an sutureless valve, because this illustration demonstrates that an oversized valve may not open or may not expand well, and as a result the valve is not opening properly and can result in significant reduction in effective orifice area. Okay, now that we have appropriately sized and selected the desired valve, our next step is to take 3 stitches along the annulus, and this is taken at the nadir of the coronary cusps, and these 3 stitches are then taken out through the loops provided in the sutureless valve. These are our guiding sutures, and in perceval valve we need to take 3. Depending on the choice of the valve, we have different ways of guiding the sutureless valve into annulus. So the purpose of these stitches is so that the suture valve is deployed at a correct position, which is the collar of the valve should be at the level of the junction between the cusps and the ventricle. So the aortoventricular continuity, at that junction we should deploy our valve. So this illustration shows the valve which is loaded in the holder, and the 3 stitches are aligned so that the valve is placed in appropriate position. Now it is very important to direct this valve in the LVOT in the right position so as that it deploys in line with the LVOT. And once we are happy with the position, we then rotate this knob in clockwise direction so that the valve gets deployed. Once the valve is deployed, we will close the aortotomy and will follow the same steps of coming off bypass and decannulating and closure of the chest. Now again, one question here, as we saw that sutureless means not completely sutureless, and we need to take maximum of 3 stitches, not more than 3 stitches, to place a sutureless valve. The second question is, why sutureless? Now we can obviously see that it has significantly reduced the time of taking stitches all along the annulus and then tying them. So indirectly it has significantly reduced the aortic cross clamp time and the cardiopulmonary bypass time. Now this is very important in settings when we are doing surgeries in those patients who are at high risk. So obviously it is making surgery a bit more safer. The second important advantage is for a surgeon, as we saw that we don't have to take stitches and tie. It can make placement of these valves in minimally invasive surgeries a bit simpler than as compared to a conventional valve. Also, it will save some time in these procedures. At the same time, if we compare this with the TAVI valves, which are also rapidly deploying valves, the advantage of doing a sutureless valve is by open technique is that we can thoroughly debride the annulus and we can place the valve in the best position. So it might give a little upper edge over TAVI when we do a sutureless valve by open technique. So it might be like we might get a balance of both the worlds with these valves. However, we still have to see how the long-term results and how further development improves the scenario in sutureless valves. These are the different types of sutureless valves which are available, which are commonly found in practice. Coming to aortic valve replacement using a homograft, now it is important to understand that we can either use homograft to do valve replacement or root replacement. In this particular session, we are discussing only AVR. So we will talk as a valve replacement and will not discuss how we use homograft or allograft to do a root replacement. So most thing is, first we need to prepare the homograft. So while once we have got the homograft of desired size, we need to thaw it, and then we need to excise the mitral leaflet which is there along with it, and then trim the muscles, and then we need to take off these coronary buttons of the homograft, so that now it becomes ready for implantation as an AVR. So usually we should take care when we are sizing, we should use 1 or 2 millimeter smaller size than the actual annulus, so that because it takes a bit more space than the annulus. So it should not crumple and it should not deform, because then the performance of this valve will not be good. So initial steps remains the same. We do it with a transverse aortotomy. The proper excision of aortic valve and thorough debridement of annulus is important. As I already mentioned, we should size it carefully. Now the next step while implanting the homograft is to get the commissural alignment first. So we should align all 3 commissure with native aortic commissures, and then we should invert the aortic homograft and push it into LVOT, so that we can see the lower edge of the homograft aligned with our annulus, and then with running stitches we can complete this anastomosis. Once we have completed anastomosis and tied, then we pull back the aortic homograft back into the ascending aorta, and then we take running sutures to fix the cut edge of the aortic allograft to the native aorta. Now this is how it is done, but it is much more difficult than what in reality than what I have just explained. This was to give an idea how an homograft can be used to do an AVR, and it is a very useful technique if we know to do it properly, especially in a settings of infective endocarditis. Now, when it comes to AVR in adult, we have a lot of choices of prosthesis and techniques, but when it is in pediatric age group, it is challenging because the limited availability of size of the valves. Now, Ozaki procedure has really made things different in this particular age group. It is safe, effective, reproducible, and have shown very good intermediate and long-term results in terms of freedom from reoperation, AR, and from other maze events. We'll quickly see how we perform Ozaki procedure. It usually starts with sternotomy. The most important step here is to harvest pericardium and nicely stretch it over a metal plate, and then we need to fix it with glutaraldehyde. Initiation of CPB, aortic cross clamp, and cardioplegia remains same as in any other aortic surgery. Usually the aortotomy is transverse aortotomy. Again, we need to excise the valve properly, do a thorough annular debridement. Now, the reconstruction of leaflets, new aortic leaflets with pericardium are managed with use of special sizers and templates. These are commercially available, and if we see the sizer, it tells us a number corresponding to what is the distance between each commissure. So here the distance between 2 commissure is measured of RCA, then LCA, and that corresponding number is chosen on a stencil, on the template, and then that is used to draw that leaflet over the pericardium that we have prepared, including the shape of the not only the shape of the leaflet, but also the marks are made where we are going to put our stitches. So once we have drawn this, we carefully cut this and then we suture it onto the annulus. Similarly, all the 3 leaflets are reconstructed, and that's how a completed new native pericardial valve in Ozaki procedure will look like. Once this is done and valve is tested, we close the aortotomy, we come off bypass and decannulate, and the remaining pericardium which is left after taking these things is used to cover the defect. The closure is done in standard fashion. Again, as I said, it is a very good procedure to know, especially in pediatric age groups, and also in adults have given good results. Now that we have seen aortic valve replacement in a conventional way, a certain modification depending on what type of valve we are using or a newer techniques that we are available, now we will apply this principle in minimally invasive approach. So advantage of minimally invasive, as we all know, it is more cosmetic, less bleeding, less morbidity, less hospital, many more to count. So if we see the major difference between a sternotomy and minimally invasive AVR is, one is access. Obviously it is sternotomy here, and here it is upper partial sternotomy. So the common techniques that we will use for minimally invasive aortic replacements are a right upper thoracotomy and upper partial sternotomy. There is no difference between heparinization. Yes, annulation, there is a different strategy. In sternotomy, we saw that we will use aorta plus RA, whereas in mini, we will use either femoral, or sometimes even people prefer to use aorta and RA. When it comes to venting, we will usually follow RSPV venting in open technique, while in minimally invasive, it is RSPV, and if it is not possible, then we can do a pulmonary artery venting. However, if you see the most of the other steps, like application of cross clamp, cardioplegia, aortotomy, excision and debridement, valve selection, closure of aortotomy, de-airing, there is no much difference in this procedure. Theoretically, there is no much difference, but practically, as we know that minimally invasive is going to be more challenging. We should not forget to put pacing wires on arrested heart, because once the heart gets beating, it is very difficult to put pacing wire in minimally invasive cardiac surgeries, and drains as per the requirements. So basically, when we are talking about minimally invasive, we need to get used to work in small spaces, and it's a long learning curve, but the end results are very rewarding. So as a prototype, we'll just see how we do a right thoracotomy AVR. So the skin incision is usually on the second intercostal space. We divide the skin subcutaneous tissue, and then the muscle, and open the pleura, and then we put tissue spreader, apply the spreader, metal spreader, and then we take a good amount of pericardial stay stitches to bring aorta under vision. This is followed by cross clamp and aortotomy. Usually a transverse or oblique aortotomy is usually appropriate for this surgery. A good exposure of aortic valve is important, which can be achieved by taking commissural stays, and again good amount of stays on the aortic wall. Thorough excision of the valve and thorough debridement, then sizing of the valve, and taking appropriate stitches, and then anchoring the valve at the annulus, and closure of aorta, and this is the end result. So again, as I said, I have explained it in illustrated examples, and it looks all very easy here, but in real practice it's not so easy. However, once we learn to get used to it, it's a long learning curve, but once we are used to it, the results are very satisfying. Now we'll come across two important situations which I will discuss today, wherein we can have problem in our clinical practice. One is small aortic root. Now, a small aortic root means we may not be able to put a desired size of prosthesis in these patients. By that, the concept of patient prosthesis mismatch gets highlighted. This concept was given by Rahmatullah in 1978, wherein he described that if you are not able to put a desired prosthesis with effective orifice area which is more than 0.8 centimeter square per meter square, then we may not actually achieve the purpose of our surgery. And he has further classified patient prosthesis mismatch as moderate and severe depending upon the effective orifice area. So there have been a lot of studies conducted in this concept, and it has proven beyond doubt that patient prosthesis mismatch can result in suboptimal hemodynamic performance and even decrease the long-term survival of this patient. There are many theories for this. Some of them highlight on importance of failure for LV mass regression to happen over time with small size prosthesis. Also, there won't be any coronary flow reserve improvement with small size prosthesis, and many more theories have been proposed. So if we are faced in this situation with small aortic root and we are not able to put adequate size valve, then we might have to switch over and change the valve that we have decided to a low profile valve. Now there are nomograms which are available for each valve, which tells the effective orifice area of that valve. So if one valve may be better than other valve, so we can select a valve which at the same size may give a better effective orifice area. So that is called as low profile valve. So we can use a low profile valve. We can change the valve positioning from intra to supraannular position, and we have seen before this can improve the flow hemodynamics and solve the problems. The next thing that we might have to do is to do a root enlargement procedure. And the last thing might be a root replacement procedure. Again, root replacement procedure is beyond the scope of this session, and we will see quickly how to do root enlargement procedure. So there are three major posterior root enlargement procedures and one anterior root enlargement procedure. So if we see the posterior root enlargement procedure, it is Nix procedure, which divides the annulus below the nadir of NCC, and we are able to oversize the valve by one size. Whereas Nunes is extension or division of commissure between NCC and LCC and the annulus at that portion. And again, we might be able to oversize with one size, and Manukians is when we enter into the AML and we are able to oversize the valve by two sizes. So if we see here, Nix is when we divide the annulus below the nadir of NCC, and Manugian is when we enter into AML. So again, as a prototype of surgery, I will discuss Manugian's procedure. This is an oblique aortotomy, and then it has extended into the commissure between the NCC and LCC and onto the mitral valve. If we had to do Nix, our incision would have extended in this line, causing this defect. The same defect is filled with a pericardium or a Dacron patch. So its suturing starts from the edges, cut edges of the mitral leaflet and extends onto the annulus and then onto the aortic wall. Now this becomes the new annulus, and we size the new annulus. After sizing the new annulus, we are able to oversize the valve by at least two sizes. Then we take the stitches for the valve all along the annulus. When it comes to the area of the patch, the stitches are taken from outside in. So the level at which the aortic valve is now seated is at this level. So we can see that is how the annulus is enlarged. And the rest of the pericardium is used to close the aortotomy, and this is the end result of this procedure. There is another interesting technique which is being described now by Young et al. And if we see this, the incision, the aortotomy is usually a transverse aortotomy, and we stop at a point above the NCC LCC commissure, and then we extend vertically downwards to cut across this commissure, and then the incision is extended below the LCC and NCC, so that this becomes the Y of the incision. So we can see here that the native aorta is cut open in this fashion, and that is the defect that we have created here. Now we take a hemashield or a pericardial patch here, and that is used to suture starting from this end of the limb of the Y incision and to the NCC end of the limb of the Y incision. So all the way this patch is anchored here, and then we climb up onto the cut commissural post of the aorta in both sides. I hope I am able to make it clear. So the patch is anchored here below the cut horizontal portion of this incision. The patch is anchored, which also happens to be the aortomitral continuity area, and then the suture line is then extended onto the commissural post, onto the native aorta, again to the commissural post, onto the native aorta of the cut aortic portion. We should be careful that we should not distort the left coronary artery too much. So with the incision should not go up way beyond the coronary artery. So once this defect is closed with this patch, now we have actually oversized we can put an at least by 3 to 4 sizes up. For this we now take stitches all along the native annulus which is there, and when it comes to the patch, again we take from outside in stitches. Here we have placed the valve, and the valve is placed, and if we see from inside the valve, we can see the pericardial, we can see the patch that is used to enlarge the annulus in the subcommissural portion. So in this way, it is possible to put at least 3 to 4 oversized valve as claimed by the authors. In terms of anterior root enlargement procedures, these are commonly performed in pediatric age group. Now if we see, the difference here is, apart from the standard cannulation and CPB initiation, the aortotomy is vertical, and then it also involves an incision on the right ventricular outflow tract, taking care we don't damage any major coronaries as well as pulmonary valve. Now the defect is seen here. This is the RVOT incision and this is the aortic incision, and then we need to join these two things to create a VSD under vision. This cut is normally in between the left, the LCC RCC commissure, and to the left of the RCC button or the ostium, and then extending into the RVOT. So once we have made this opening, it will look something like this. There will be a ventricular septal defect in subaortic or subpulmonary position, and this is the RVOT opening, and this is the aortotomy opening. Now we need to close this defect with a two-layered patch, an oval-shaped two-layered patch. So if you see the patch, this particular portion of the patch will be used to close the ventricular septal defect. This will form the new annulus at this junction. So we can see that we can enlarge significantly the aortic annulus, and then this portion we can flip it, one to close the aortic wall and other one to close the RVOT. So that is the end result, and we can see that we have taken stitches all along the existing aortic annulus, and when it comes to the patch, from outside in, and the valve gets seated inside. Okay. The next important situation that we can encounter in our practice is of infective endocarditis, which can involve native or prosthetic valve. The surgery is very challenging and is associated with high postoperative morbidity and mortality. General principles of AVR, which we have seen, remains the same. Thorough debridement of the infective material is essential and may leave behind defects which will need proper reconstruction. Now in this figure, we can see that there is infective endocarditis which is involving the aortic cusps. There is, in this, it shows the involvement of annulus, and then it has extended into surrounding structure causing abscesses. So it can vary in what presentation we may see. Homograft has shown to be having very good results in setting of acute infection. When we do surgery in acute infective stages, homograft has shown good results. So centers with experience in homografts have shown good results. When it comes to choice of mechanical and bioprosthetic, the same rules as choosing this prosthesis in general situations apply, as there is no superiority of one over other. So if we see, usually we may be encountering one of these three situations. Infection may be limited to the leaflets, and in this situation we might get away with aortic valve repair or replacement. If it involves the annulus, we might have to do thorough debridement of that portion and annular reconstruction with either pericardial or Dacron patch. And if we see extreme situation when it extends into surrounding tissues and forms abscess, then we might have to do extensive reconstructions plus minus root replacement procedures. So one of the challenging situation in infective endocarditis, which we will quickly go through, is when it involves aortomitral curtain, or when the infective endocarditis involve both the valves. So doing AVR in this situation is also very challenging. So usually we have to do better to do bicable cannulation in infective endocarditis situation, because we don't know what we are going to expect once we open the heart. So it is safe to do bicable cannulation, loop and snare, both SVC, IVC. Now this particular illustration or this particular surgery is called as commando procedure. This is one of the illustration to demonstrate this surgery. There are different ways of doing it. Here it is shown by doing an transverse aortotomy, which is extended down into the left coronary cusp, as well as the same incision is extended into the aortic root. And to improve the exposure, we can even divide the SVC so that we can now see aortic valve as well as mitral valve. Aortic valve has been excised, mitral valve anterior leaflet also has been excised. So this leaves behind this defect. As we see, the PML is intact, so we can take stitches all along the PML and anchor the mitral valve in that over those stitches. Now to close this defect, we take a pericardial or a Dacron patch, fold it onto itself, and then pass stitches from outside in to complete this defect. So this defect is completed with a folded patch here, and the one half of the patch is used to close the LA, and then from this end we will take the remainder of aortic stitches, and the rest of the aortic stitches will be taken on the annulus, and the remainder of the stitches will be taken through the patch, and the valve will be seated in this particular position, and this patch will be used to close the aorta. So it is a procedure which is described to address the situation when we have double valve endocarditis, or in any situation when we lose the aortomitral curtain. And just to give an idea about this procedure, this illustration is used. It's a challenging surgery with high mortality and morbidity in post-operative period. Now coming to the last concept for the session is the transcatheter AVR. Now we will not go into detail of transcatheter AVR because it is beyond the scope of this and it will make the presentation very long. So why this transcatheter AVR has come into picture is again to address those patients who were very sick to undergo conventional AVR, and who were very symptomatic that we couldn't leave them just like that. So to find a balance of this high risk patient, transcatheter AVR therapy was introduced, and over the time we have seen that it is doing really well. The results are very good as shown by partner 1, 2 and 3 trials, and now the indications has moved from earlier to very high risk to high risk, and now even as extended into the intermediate risk category. So when we are deciding for a patient for transcatheter AVR, we need to consider many things before we decide and finalize our decision. So we need to see whether it is a native or valve-in-valve TAVR. We need to decide on access and how good we can conduct the procedure depending upon what access we have. So it can be transfemoral, it can be transapical, or it can be transaxillary. We need to look at the coronary locations. We need to see how is the calcification and what is the risk of paravalvular leaks. We should also think about conduction disorders which can happen after the procedures. We should think about risk of patient prosthesis mismatch. We should also look at the anatomy of ascending and descending aorta. How is the lie of the aorta, whether it is too horizontal or too vertical. And again, associated diseases have to be taken into consideration before we finalize the plan. Now these are the types of valves which are available, and many more are in process of coming. If we just see the characteristics, I know it's a busy slide, but we are not going to go into detail of this, but there are different companies which are manufacturing these valves. To name a few are like Edwards, Medtronic, Boston Scientific, Abbott, and the stents which are made of different metals like nitinol or cobalt chromium. Few of them are self-expanding, few of them are balloon expanding, bovine, porcine, intraannular, supraannular, ranging from 18 to 30 millimeters, fitting almost all size of aortic annulus. Some of them are only for transfemoral, some are for all approaches. Some of them can be retrievable and can be repositioning. Some of them cannot be repositioned. And interesting to note is the vessel diameter requirement. And if we see the newer ones, we can now conduct these procedures even with the vessel size of like 5 millimeters. So that much advancement is being happening now in terms of the delivery devices of these valves. So if we quickly see, I am going to simplify this procedure just for understanding. It is a very complex procedure and takes a lot of steps and a lot of understanding about anatomy and a thorough knowledge of TOE and cath projections. But we will simplify it for our understanding and for simplification. We need to decide on what approach that we are going to follow. Our main aim is to allow the guide wires and the working wires into LV and be in proper position and confirmed with multiple cath views and TOE. Then these are the delivering devices which already has the valve seated on them. So with this delivery device, we need to place this delivery device in the best position. This is the position where it is across the aortic valve, and we should confirm this again with multiple views and TOE. And then once we are sure about the positioning, we need to deploy these valves. Some of them are balloon deploy, some of them are self-deployable. So depending on what it is, we need to deploy the valve, and we need to so the valve seats here and the problem is over. So this is oversimplified version of TAVI, just to get the concept right in this session. But the actual procedure involves multiple steps and has got a lot of pre-op workup and post-op management to do. So with this note, I'm going to end today's session. This was an attempt to give an idea about how a conventional aortic valve replacement would be done, and what are the various areas which are now coming up in terms of aortic valve replacement that we should look for and gain more knowledge. There would be more sessions on each of these later in future. These are the references which we have used to make this presentation. I hope this was informative. I thank everyone for patiently listening, and if there are any more questions or any doubts, we are happy to take. Thank you.